Surgery can be scary and filled with uncertainties. There are certain procedures and steps that one should be taken through before going into the operating theatre, and this includes giving an informed consent after a basic understanding of what kind of surgery one is to undergo. Sada Hassan, the Standard's health and science reporter, spent time in one of the operating theatres with Dr. Kilian Kariuki, an anesthesiologist at the Kenyatta University Teaching and Referral Hospital, and brings you these details. I'm Dr. Masi Korir, and this is Health Digest.
Some surgeries will require you to be put into sleep, while some will allow you to stay awake during the procedure. The general process of inducing sleep is done through the use of anesthetics, which numb sensation in certain areas of the body and prevents pain and discomfort. Dr. Kilian Kariuki, an anesthesiologist working at Kenyatta University Teaching and Referral Hospital, takes us through the anesthesia process during surgery of a patient. After a patient has been identified and a need for surgery established while in the ward, preparation is done to establish an underlying condition. Today, patient NN will undergo a surgery, and she has been informed prior of the process that will take place and given consent.
When we are receiving the patient here, we've already seen the patient before, in the ward or in the preoperative clinic. Yeah? Anesthesia clinic, we see in both situations where no issues regarding does she have any cardiovascular disease, is there any condition like diabetes or any chronic disease that may affect the outcome of the anesthesia, or any disease that we need to optimize. If she is a hypertensive, or the person is a hypertensive and we need to optimize the antihypertensive agents. If it's a diabetic patient, we need to plan different from a patient who doesn't have diabetes regarding the feeding, the controlling of the sugars. So we do all that before. We ask about allergies and any prior history of surgery, all those. We have to ask all those questions. All this is targeted towards patient safety. Because you don't want to come in here, then there are things you don't know, then you get an adverse outcome. So it's all geared towards a good outcome for the patient. We want 100% of the patients that come in here to also 100% of the patients to live with a good outcome.
Preparation time will vary from one patient to another. Emergency cases often pose a challenge since one does not have much time. Some hospitals will use a health questionnaire in a pre-assessment clinic before the operation day.
Quite a number of drugs. Yeah? We also have to ask about any allergies, prior drug use, especially in our setup. We have a lot of herbal medication which can affect even the anesthetic agents we give, may cause even more bleeding and whatnot. So we have to get a history of everything that is being used and now tailor it and plan our anesthesia appropriately. Preoperatively, you can even ask another specialty like a cardiologist or someone else to see the patient to help in the optimization, so that we go, again, tailored towards patient safety. Yes. The other issue is we have discussions with the patient preoperatively, because they have to understand what procedure is being done, what expectations are there regarding the procedure, and on our aspect in anesthesia, what kind of anesthesia will we use, because there are various types of anesthesia. In this situation, we are going to use general anesthesia, so the patient is going to be completely asleep, because you can use a spinal anesthesia, there is epidural anesthesia, there is also regional anesthesia, where we do specific nerve blocks. So all these discussions you have to have with the patient before, so that when they come, they know exactly what is happening. That's part of the informed consent, and in that you even develop some rapport with the patient, and now at least they are part of the they feel like they're part of the process also.
Surgery rooms are divided into different regions based on the types of preparation required or necessity. A standard one will have a preparation or induction room and the main theatre.
So in case we want to start preparing the patient, we can even induce the patient, put them under anesthesia here, then transfer them there for the procedure. If it's a regional block, we can do it here, then move the patient there. It helps reduce the waiting times.
There are several anesthetic drugs that can be used on a patient before the start of the operation and during the procedure. Majority include pain relievers, which eases pain afterwards, muscle relaxants, which relax the muscles completely, and the anesthetics use a ventilator to do the breathing for you, antibiotics and medicines to manage the blood pressure.
The older patient, now we have to look at the geriatric components of the anesthetic technique. So you may have to tailor your drugs a bit more. Post-operatively, you may have to monitor the patient even more closely. They get more delirious, and you also assess for comorbidities. You know, when people are growing older, you get these diseases like hypertension, diabetes, more and more, and they are likely to be on more medication than the younger population. So you have to look at the patient as a whole. Yeah? Then if you find a patient on multiple medication, now you have to adjust your treatment. Essentially plan. You must have an anesthetic plan before you put the patient to. You bring the patient to theater and start the procedure. This is the anesthesia machine. When you say a patient is general anesthesia, this is essentially the machine we are discussing. There are different models, different makes, but what it does is the same, essentially the same. So you just switch it on, and it has a lot of safety features to ensure there are no adverse events with the patient when the patient is on the machine. So you must know how to operate it. It's not something you can just come. Yeah. So you must know how to operate the machine. So it's connected to oxygen. There is medical. All those connections are there at the back. Yeah. So with this machine, as you'll see, when you connect the patient, once you put the patient here, because the patient is paralyzed, like for that procedure, it breathes for the patient. Yeah. And it also has a monitor which shows us how. You see, it has various modes. These are modes for breathing for the patient. Yeah? All these. So you can select. Yeah? So this is based on the particular patient you're dealing with. So you'll see when the patient is there, you'll see it has graphs and loops, all sorts of waveforms to help you monitor what exactly you're doing and how the lung is responding. Yeah? So this is mainly for breathing. Yeah? So it breathes for the patient, and here it removes the carbon dioxide from the system. Yeah? These are the drugs we use to keep the patient asleep. This is actually a liquid, but once air is passed through, it turns into a gas, because this is a vaporizer. So this is one of the drugs. We use quite a number. So you have to measure how much you're giving, as you can see. Them, but you can only use one at a time. Yeah?
On average, the induction process will take 5 minutes with no complications. The general anesthetic can be given as a liquid, which is injected into your veins through a cannula, a thin plastic tube that feeds into a vein and is usually on the back of your hand, or through a gas that you breathe in through a mask.
It will definitely affect different systems. It will affect the heart, it will affect the breathing, it will affect it. So as we are moving from this awake state into general anesthesia, we need monitoring. We need to know exactly what is happening. These wires over here gives us the ECG. It also reflects the heart rate. This is the pulse oximeter. It tells us oxygenation, but also gives us a pulse rate. Yeah, and we also have the blood pressure curve. So what we do, you give oxygen. called pre-oxygenation. I just give 100% oxygen before she falls asleep.
Anesthetics take effect immediately and one starts feeling lightheaded and becomes unconscious within a minute. Anesthesiologists stay throughout the operation procedure, ensuring that you keep on receiving the anesthetics and you stay in a controlled state of unconsciousness.
The most important thing is that there must be oxygen.
So what have you given her?
No, it's just we've given fentanyl, an opioid, to help. It helps with the pain management. Also to keep her blood pressures from shooting too high when we start. EBP fine.
There are 4 stages of anesthesia: analgesia or disorientation, where a patient remains conscious, can hear and see and feels like in a dream state. Stage 2 is called excitement, where there is loss of consciousness up to gain of rhythmical respiration. Stage 3, the surgical anesthesia, which is the onset of regular respiration to cessation of spontaneous breathing. And stage 4, the medullary paralysis, where there is no breathing, leading to failure of air circulation and ultimately death.
So because there is paralysis and all, we've taken over the breathing, and now we are monitoring the heart. And now what we do, we'll give quite a number of drugs to help with the pain management. And as you may notice, we are also giving this, as I told you. This one, it's called isoflurane. It's a liquid drug, but once it goes through the vaporizer, it becomes a vapor. And that's what we use. It's called the maintenance phase of anesthesia. Putting the patient to sleep, we usually call it the induction phase. Then we have to maintain the anesthesia. So the maintenance phase, there are quite a number of options, but most commonly we use the isoflurane. Yeah? You can still use a different technique where you just maintain with the intravenous drugs, but here we are using the vapor. Yeah? So the drug is actually coming in and going straight to the lungs, then going into the system, keeping the patient asleep. And we can vary the doses based on what is these markings here. So you can vary the doses based on the blood pressure, because it also causes a drop in blood pressure. So you have to monitor the drug. Yeah?
Anesthetics work by blocking the signals that pass along your nerves to your brain. When the anesthetic wears off, you start to feel normal sensation again. Local anesthetics and general anesthetics are 2 commonly used types of anesthetics.
Anesthesia essentially encompasses analgesia, amnesia, yeah? Where you don't want the patient to feel pain during the procedure or after the procedure. You don't want the patient to remember the procedure. More like we call a hypnosis, amnesia. You don't want the patient to have recall of the procedure, because that may be traumatic to the patient. The modern aspect of anesthesia, we also have the paralysis, the muscle relaxant aspect, so that we have better exposure of the surgical field. And a key thing is ensuring that when the patient comes to theater, you are monitoring their vital signs. You are trying to ensure you maintain the physiology of the body, so that the patient actually lives through the operation, survives the operation, and has a good outcome, is able to go home. So among the drugs we give, we also give antibiotics to prevent infections that may occur, which cause a lot of morbidity and mortality if not given. And as you can see, the whole team is also trying to ensure sterility. You don't want anyone contaminating the field.
Early operating theatres in an educational setting had raised tables or chairs at the center for performing operations, surrounded by steep tiers of standing stalls for students and other spectators to observe the case in progress. The surgeons wore street clothes with an apron to protect them from bloodstains, and they operated barehanded with unsterilized instruments and supplies. A modern standard operating theatre now has more than 5 personnel, depending on the type of operation to be carried out.
Would be an anesthesiologist, there is the anesthetic assistant, yes. Then there is a surgical team. We have the surgeon as the scrub nurse. Also may have an assistant surgeon. And now we have a runner nurse. So once the team is scrubbed, they can't touch anything else. So they need people to pick things for them. So we have someone, the runner nurse, and we also have there's a team that helps us with the cleaning and ensuring. As you can see, all surfaces are quite clean. Yeah?
Technology has improved a lot of factors in the medical world. In this case, anesthesia is safer today than it was in the past. In very rare cases, anesthesia can cause complications in children. However, the risks depend on the kind of procedure and the type of anesthesia used.
Children are not small adults. You have to look at their physiology as a completely different aspect. In terms of, you may be using the same drug, but you have to know what are the differences in terms of how they compensate with the heart, with the breathing. So you have to take all that into account. The drugs are essentially more or less the same, but it's the physiology and what you do to avoid problems that may occur. There are different ways of giving anesthesia. There is a general anesthesia. I think that is what most people are familiar with. You're given a drug, you sleep. But there is also the spinal anesthesia, which is used quite a bit, especially in the maternity theaters. But mostly, if you look at, if surgeries are from the waist down, you find a lot of spinal anesthesia being used. So the patient from the waist up is fine. He's even talking to you. There is no pain. And the procedure continues, and the patient is finished. Epidural anesthesia, similar. Patient is awake, communicating, and you're able to do the procedure, but there's no pain. Yeah? Regional anesthesia, you can do nerve blocks. Let's say we're operating on the upper limb, then you block the nerves here. So the upper limb becomes numb, and you're able to do the surgery. The patient is awake. Yeah? All these are tailored to the specific patient and the specific surgery. Yeah?
Inside an operating theatre, some challenges may arise. Different patients have varying airway sizes that allows the passage of air.
During induction, you have to assess. One of the things we assess is the airway. As you saw me using that, it's called a laryngoscope. To open, when I open the mouth, I put it in, then I put the tube. It's called a laryngoscope. Then you're able to see the vocal cords and the trachea, and you put the tube. Some patients you can't see clearly. It becomes, we call it a difficult airway. And in anesthesia, there are also difficult airway specialists. You may have a patient has a tumor in the mouth, so you can't see the airway. So they are difficult airway specialists, and they are also flexible laryngoscopes that can help you access the airway. So you have to assess before. You can't just come and push the drug, and you may find you can't access. Yeah. We also have emergency algorithms for such situations. That's why we have this emergency trolley. And even on that trolley, we have some emergency airway items, such that if you get stuck, remember you've given the drugs. So you need an intervention to ensure the patient is okay.
An anesthesiologist is an all-round physician who plays a bigger role than just putting patients to sleep. He or she plays a role before the operation, during, after, and outside of surgery in managing the pain of a patient.
Theatre list is posted the day before, and you've seen the patients the day before or earlier. and you've already documented and written what is required. So usually you come in the morning, you can do a final review of the patients, then come into theater. You have to prepare everything. So you order drugs, prepare your equipment, and prepare the drugs. Ensure everything is there and is safe. You have to do a check of the anesthesia machine. Every time you switch it on, it has a test process. You don't want it failing when a patient is on the machine. Then essentially you start we call it a theater list. You start the list. You start with the first patient, moving along. Once you're done with the cases you're doing, you also have to go and review the patients.
After an operation, the anesthesiologist will stop the anesthetic, allowing you to gradually wake up. Usually, this will take a varying margin of time depending on a patient. One is likely to experience side effects such as nausea, vomiting, muscle aches, or even dry mouth.
So we're in the process. It had already been started of reversing the anesthesia. So what happens is, with this agent that you saw us switch on, you go through stages of anesthesia. So we usually switch to 100% when you are inducing and when you are coming out of when you are reversing the patient. It gives us a safety margin in terms of, because you are breathing 21%, you have a lot of nitrogen in your lungs. So we remove all the nitrogen. It gives us a safety margin. In case of any complication, you still have a lot of oxygen reserve in your lungs. So what we usually do, once they are stable, here we move them to what we call the PACU. So they are monitored until they are fully awake before they go to the ward setup. Yeah, because you can't take a patient who's half asleep to the ward.
An anesthesiologist usually delivers the anesthesia medications through an intravenous line in your arm. Some of the drugs may include flumazenil and naloxone, which reverses the effects of the opioids.
Yeah, you go off this. If you're using this, you put 100% oxygen. You allow them to breathe on their own. Once you see there is some muscle activity, then you give your reversal agent. Okay? Once now there is good enough function in terms of breathing, now you can actually, and you can see the patient has come up in the stages of anesthesia. Yeah? You can even wait until she is able to respond to your voice, like instructions. But because of this cough, sometimes they cough a lot. When she's breathing here, you can actually see the bag is moving. So that's a very important thing. It may seem old school, but it's very, very important. Because we have all this monitoring. Because we can even see when she breathes, you see those waves, these waves.
Some people have memory trouble after they get general anesthesia. Others are confused for a few days after their surgery, which is called delirium. And usually it goes away after about a week.
The reversal agents, the main thing we want to reverse is the muscle relaxant. Because remember those muscle relaxants we use, they are all quite, not in terms of the medical field, quite new. But what you do, it's a whole pharmacological, physiological process, but you want to reverse the effect of the muscle relaxant at the receptor level so that now the normal process of muscle contraction goes on. Because if I give someone a muscle relaxant, even if they are awake, it will take effect. They'll just fall down and stop breathing. So for her to be awake, breathing on her own, yeah, it means the muscle relaxant has been reversed.
Inducing and reversing a patient during surgery at the most critical moments. On average, it takes about 5 to 10 minutes for a patient to wake up after surgery. But the most important aspect of this whole process is to ensure the safety of a patient. Sada Hassan for Health Digest, KTN News.
Still to come on Doctor's Diary is a story of Dr. Andrew Nyaoncha, a neurosurgeon with a purpose to serve people who would otherwise not have access to his kind of services.
My first year, we did just under 250 cases, elective cases, for For neurosurgery, that is about 6 cases every week. That is a lot of work.